Hello, I'm David K. Gyro, Chief Medical Officer with Point Coupee Parish District 3 Fire, and today we're going to be going over nasal airways, all about nasal airways. I think you're going to find this very interesting. We're actually going to do a live procedure on Timmy, our fellow EMR right here, and today I want to talk a little about nasal airways. First of all, let's kind of backtrack a little bit. Whenever somebody is unresponsive or unconscious, they're in risk of having compromised airway, which means they could possibly vomit or throw up or whatever, and they could get like fluids and stuff into their lungs. We don't want that to happen. We always want to secure people's airways. And for somebody that's completely unresponsive, completely unconscious, no gag reflex, normally we will use the OPA or the oropharyngeal airway. We're going to go over this on another video, but in the event that they do have a gag reflex, we're going to revert to the nasal airway. So let's put this back here and let's discuss the nasal airway. Timmy's going to go pull a nasal airway out. Here's a pack of about 6 different sizes that we carry on our rescue trucks here at District 3. And let's go ahead and kind of briefly show you what they look like. And we're going to go over some contraindications and indications and everything. So in the pack right here, you'll see what they look like. They're kind of curved, and we'll put one out the pack. And notice they're very rubbery feeling, they're very kind of slippery, and they go into the nose, of course. The very first thing that you want to do is see if that you can use an airway to begin with. There are some contraindications to using nasal airways. Number one would be, when would you not want to use an airway, a nasal airway? Basically, if somebody has any kind of a skull fracture, facial fracture, fracture of the roof of the mouth, or basal skull fracture.
Most facial trauma.
Exactly, most facial trauma, because you got to think, you don't want to push this into some tissues that may be going into the brain or other tissues in the head. Basically, if anybody's got any polyps or anything, or any nasal obstructions in their nose, you don't want to push it past that or whatever.
How can we recognize if someone has facial trauma wouldn't be able to be used?
Sure, absolutely. You're going to notice swelling in the face, first of all. If their eyes are starting to be swollen, one side of their face or whatever starts to be swollen, battle signs, which is a bluish markings behind the ears, that shows basal skull fracture. CSF, which is cerebral spinal fluid, absolutely. You look in the ears, and if you see any clear fluid along with the blood, that's going to notify you of a possible skull fracture, absolutely, definitely. A lot of people like to take a 4x4 gauze and put it in the fluid, and they'll see the clear fluid separating from the blood. And so you definitely would not want to use a nasal airway in one of those situations. Yeah, so that's pretty much it. So whenever you want to measure the airway, you want to make sure you have the right size. They come in different sizes. They come by the French sizes, which is 22 French, as this one is, and a 5.0. And
we go from 22 French all the way up to 32 French.
Exactly. Yes, exactly.
So, which is about 5.0 all the way up to 7.5.
Exactly. And generally speaking, women will take about a 6. Average size women will take about a 6. Average size men will take about a 7. Sometimes you can go 6.5. Just kind of measure it. Just kind of judge by looking at the nose. One way to do it would be to take the airway and go from the lobe of the ear to the corner of the mouth, and that would be a good way to kind of measure. Another way would also be to take the pinky finger of the patient and kind of put side by side and look at the the diameter of the finger as related to the airway. And so once you got all those parameters in place and everything, you can go ahead and make your selection. And so once again, this is good for people that have an active gag reflex, as this is going to go in the nose, kind of behind the tongue.
This would be done more on conscious patients.
Yes, or semi-conscious patients, right? Exactly. And some ideas that we'd use that would be maybe like a narcotics overdose, Narcan, people that might have had a seizure and they're very deeply unresponsive, or any other thing like that where somebody's kind of easily arousable too. Maybe even like low blood sugars, if they're extendedly have low blood sugars and you can't get it up and they're just sleeping or whatever, you can't get them up or whatever, anything like that. And these are they're harmless too. Once you get them in here, they can stay there for a long time. They won't do any harm to the patient. So some of the contraindications you want to watch out for is, I guess you could say, is be careful when you're putting it in. Be very gentle on the patient, because we don't want to have any trauma to the nasal passages and start having bleeding or anything like that. Depending on your protocols, what they allow, sometimes we'll shoot like nose spray up, afferent nose spray.
The blood vessels.
Exactly. It'll constrict the blood vessels. It'll actually dilate the nasal openings and make it easier. If your protocols call for that, you can do that as well. So let's go ahead and put the nasal airway in. I think that's what you're all waiting for, right? So we're going to go ahead and put the nasal airway in.
Okay, so let's touch on what you use to put it in.
Before you put the nasal airway in, you want to lubricate it very, very well and with some type of lubricating jelly. And when you're doing that, you want to make sure you don't get into the actual hole right here, because you got to think they're going to be inhaling. You don't want them to inhale any KY jelly into their lungs or anything. So just make sure you don't get any KY jelly in the actual opening right here.
On either side, really, because
exactly.
You want to block the opening too from air being able to get out.
Absolutely. So. And before I put the airway in, I'm going to go ahead and go over some general techniques before you get the airway in the nose. So basically, you'll notice that this thing has a bevel on it, so it's kind of curved like this. So what you want to do is you want to put the bevel facing the septum of the nose, the inside of the nose like this. We want to have it facing the inside of the nose. So actually it's going to kind of go in like this. So most of these airways are made for right side nasal airway to go in as like this. If you have to go to the opposite, you're going to flip it upside down. And when you first need a little bit of resistance, you're going to flip it back like this. So we're going to go, we're actually going to go, I think your nose is going to be the left side we're going to use, right? Timmy's left nostril is a little bit bigger than his right, so we're going to go that way, which means we're going to take the bevel and we're going to kind of go upside down and we're going to flip it like when we go halfway through like this. So what's going to happen is when we're going in, we're going to meet a little bit of a resistance when we first go into the nose, and we're going to kind of gently go back and forth till we get past that resistance, and we're going to kind of flip it back right side.
From that point on, it should glide right in.
From that point on, it goes right in.
Sailing.
Not a problem at all.
Yep.
Sometimes it will cause the patient to have, tearing up or whatever, or it'll be kind of like.
That's to be expected.
Exactly.
You're putting a foreign object up someone's nose.
Exactly. You're going to feel a little bit of pressure in there
Yeah.
also. So let's go, without further ado, let's go ahead and put the nasal airway in and see how it works. Okay, and we are ready to perform the procedure for a nasal airway. And so as you see, we have the nasal trumpet in a hand right here. And we're going to go ahead and have copious amounts of lubricating jelly. We want to get that thing lubed up really, really good.
Be generous.
Yes, be generous. Right.
Very generous.
Very, very generous.
Get it all over it. Like I said, like he said, make sure not to get any in the hole.
Right. And if you do get some in the hole, like you can always blow it out. That's why they call it a nasal trumpet, because you can blow it out.
So you can blow it out.
All right, so as you see now, we have it very, very lubed up, very, very good to go. Super, super slippery, super, super slick. Now, if you notice the bevel right here, see how it's kind of at an angle? Remember, we want that bevel to face toward the septum or toward the inner part of the nose. Now, what we're going to do is we're going to go in the nose till we hit a little bit of resistance. Then we're going to go a little bit further. We're going to flip it upside down, and it should slide right in. Very, very simple. So you ready, Tim? All right, so here we go. We're going to go right into the nose. Just be very still. And we're going to go right here. All right, so let's kind of slip it upside down. All right, and here we go. In, almost there, and we are there. Okay. All right, now you can back up. Here we go. How does that feel, Tim? Can you breathe? Okay.
Really good.
Okay. You had shedding a tear a little bit. Okay.
Yep.
All right. So back it up a little bit. There you go. Now the nasal airway is in. We're going to pull it out in just a second right here, and this will protect his airway if he's semi-responsive, semi-unconscious, or whatever.
Like I said, so let's go real quick before we leave. What are reasons you do not do it?
Right. If you have any type of a possible skull fracture, any kind of a fracture in the roof of the mouth or in the facial fractures or anything, we don't want to be putting this in the nasal airways, or any kind of polyps in the nose. Make sure, once again, use the bigger nares. You're going to have one bigger and one smaller. Everybody has one bigger and one smaller. And that's pretty much it. There's nothing to it. Just remember, don't be discouraged when you first hit that part where you get a little bit of resistance going. Don't be discouraged, because expect that. When you hit that resistance, you want to kind of twist it a little bit or wiggle it and get past that resistance. And once again, we're not going straight up. We're going to go pretty much in the nose.
Because what's a common misconception?
So, I'm sorry, go ahead. A common misconception?
Yes.
Would be
that it goes up.
Yes, like I said, it goes. We don't want it to go up. We're actually making it go like forward, a little bit up and forward into those. Then it's going to kind of veer down into the nasopharynx back there. But there you go. And as you can see, Timmy's tolerating it pretty well. He's got a little bit of tears coming out, but that's to be expected. That's a normal response.
Let's pull it out.
All right, let's pull it out. Nice and gentle, nice and gentle, nice and gentle, nice and gentle. All right, there you go. Here you go. There it is. So before we leave, Timmy, kind of tell us what your experience was like.
So I would not recommend you do this on just anyone.
You have to be trained, right?
You have to be trained. That's what I'm saying. But I would, if you're in training, this is a great way to learn what it's like. Because I'm a stickler for, trying procedures out that are able to be done on you, so you can get a feel for what it's like. Mm-hmm. Because, in my experience, it's like, you do MPAs on people. It's like, I was thinking, I want to learn what it's like to have that on me. I want to know what the feeling's like.
Absolutely, yes.
So, because if I'm doing it on people all the time, I want to know what it feels like.
Right, just like CPR. When you're doing something on a mannequin, it's not really realistic.
Exactly.
When you're doing a real person, it's very realistic.
It's always good. It's good if your protocols allow for it, if you can, to train on people and do these procedures on each other.
And we got to think, no two people are alike, right?
No two people are alike. A mannequin, what's a mannequin? It's like cookie cutter.
Right.
They're all the same, but that's not. You don't get that in the medical field and pre-hospital. And everybody's different because you're meeting people where they are.
Exactly.
So that's big,
and
basically.
Sure, I want to close this video out. Thank you for joining us. And if you are in an EMT class or an EMR class and y'all are learning about nasal procedures and stuff like this, go ahead and ask your instructor, hey, pull some out and see if you can actually do these procedures on yourselves in your class. It doesn't really hurt that bad. It doesn't really even hurt. It's kind of discomfortable.
It doesn't hurt. It just feels very stuffy.
Exactly, right. And it'll be a great experience for you to have on another human being. something you can take with you for the rest of your career. But anyway, that being said, thank you for joining us on this video. Like, share, and subscribe. Ring that bell, and we're going to see you on the next video. Thanks a lot.